Okay, so this is a tool that we've been working on that extends back to collaboration we've had going um, through previous CFA work with the economic team and the modeling team. And so I will show a few slides that describe the model that we're using, basically the mathematics that are behind the tool, the engine that makes the tool work. And then Willy will show a Shiny web application that implements a version of the model. And we're hoping to get some feedback on um, that tool and different things we can do with it and whether what kind of utility we see in this kind of thing for public health collaboration type work. Um, so the model is a multi-group transmission and vaccination model. And it was originally designed as a tool for investigating intervention, specifically vaccination intervention impacts on population health disparities. And these we've been building these tools on GitHub and learning different ways of sharing things, and including code and applications, and now slides on GitHub. So you can see a link down here where there's a HTML version of these slides that you can look at if you want. And so the motivation of this model is that we know that infectious disease outbreaks can have disparate impacts across different subgroups of people living in our communities. And if one group has a higher infection rate than the other due to an outbreak, there's several different mechanisms by which that could happen. And a few examples of those are that one group could have higher susceptibility to acquiring the infectious organism after exposure. Groups can have different rates, overall rates of person-to-person contact by which they might become exposed to the disease. And then there's also sort of group contact network effects where if a group has higher contact within members of their own group, that can amplify transmission within that group, especially if they're already experiencing disparities by some of the other mechanisms. We also know that disparities in vaccination coverage can also exist. And so couple of the main questions that we had surrounding that were, how do efforts to reduce vaccine disparity interact with disparate transmission outcomes? And that's a good question for a model like this to answer. And then on more of the economic side, can interventions that are aimed at reducing disparities be cost effective? There are resources that you put in specifically to not only getting more vaccines out there, but reducing the disparities in coverage. What kind of impacts can those efforts have in sort of cost-effective economic terms? So here's a bunch of math. The model is basically an SIR model, which is one of the standard sort of math transmission style of models. So we have the SIR groups, which are susceptible, infectious, and removed. And you notice that there's 6 differential equations here instead of the 3. That's because we split each of those SIRs into the 2 groups. So we have group A and group B. And there's really only a few parameters in this model here on the left. The n's are the 2 group population sizes. And then as far as the epidemiological parameters, we have gamma, which is end of infectiousness rate, sometimes called the recovery rate, but it could also include people who die from the disease. And then, so basically the rate at which someone becomes no longer infectious to others after they acquire the disease. And then we have beta, which are the transmission rates, and they have IJ subscripts or A and B subscripts here because we're representing a transmission in sort of the 4 different directions group-wise that transmission can occur. A to A, B to B, or A to B in either direction. So not that many parameters in this model, but then there's a lot of information buried within these beta parameters because it includes both contacts and acquisition of the organism after a contact between an S and an I. And so these parameters that are in these beta equations are some of the ones that we sort of investigate their effects as inputs. So first we have Q, which is the probability of infection per at-risk contact for group A or B. So there's a QA or a QB depending on which direction the transmission is happening in the transmission rate. So the Q is where you sort of represent that susceptibility difference between the two groups. If one group has sort of underlying, more underlying health problems or some other rates of conditions that make them more susceptible to acquiring an organism for a given amount of contact, then you can represent that there. Then for the contact rates themselves, there are these A parameters, which are the overall contact rate of group I. So that's just basically the number of people seen per time by members of a group of the group. And so two groups might have a different overall contact rate if, for example, they tend to have different kinds of jobs that bring them into more contact with people. Early in COVID, the idea of essential workers was a big idea where people who weren't able to isolate contact more people because of their job, which could have different rates in different groups. It could also be related to sort of a different average household size of different groups or different, sort of family sizes or rates of attending social gatherings and so on. And then the last one here is these epsilon parameters, which is representing sort of preferential mixing within someone's group. So the degree to which your contacts tend to be within your own group more so than you would expect sort of on average if there was completely random mixing irrespective of groups. So if the epsilon goes between 0 and 1, if it's 0, then that means contacts occur proportionally to the overall group sizes and contact rates. So that's sort of the random mixing assumption. And then all the way to if epsilon was equal to 1, then that would mean all of your contacts are only within your own group and none with the other. And generally, we expect it to be somewhere between those extremes.
Yeah, this is really, thank you, Damon, for walking us through this. This
Yeah.
is extremely helpful. So there's probably a good reason for this, but so beta ij is not a function of qj. Is that right? So like
Yeah.
AJ
So
is in there,
yeah.
or epsilon J is in there, but QJ is not in the BIJ, the beta IJ.
Right. I is the sort of receiver of the transmission. And so the
Gotcha.
QI is a susceptibility to acquisition of sort of the
Pro-
receiver, right? The
Gotcha.
S, if a SI come into contact. Yeah.
Gotcha. Group I is the right. Group I is the receiver, and Group J is the center of
Yeah.
the.
Yeah. So that's why in the SA equation, which are the susceptible A's, you have
Mm-hmm.
beta AA and beta AB. Those are
Uh-huh.
the A's potentially acquiring from either an A or a B who they contact
Mm-hmm.
is infectious, right?
Gotcha. Cool.
And then I haven't mentioned vaccination at all. We represent that kind of very simply here, where if someone is vaccinated, we assume that they're immunized, and they're basically just instantaneously removed from the susceptible class. So we represent it. There's more complicated ways to represent it, but in this version, if someone is vaccinated, we basically just assume they're removed and they're not susceptible. They're no longer eligible to acquire the organism. Um, okay. So and I didn't explain these equations. It's just safe to say that the equations take into account these assumptions that I explained in order to calculate the right beta value. And so any input you give for these in the app that will show sort of automatically gets calculated into these betas, and then it solves the differential equations. So here's the input components that you'll see on the map or on the app that Willy will show. So two population sizes, A and B. Uh, they can be different sizes generally. We have it could be half and half, but we generally sort of model like a majority and a minority group, where the minority group could be like a racial or ethnic minority or whatever different, however you're breaking up your population. Then we also input the overall transmissibility of the pathogen, which we represent with the basic reproduction number R naught. So that's something that generally for an organism that causes an outbreak is bigger than the threshold of R naught greater than 1. But you can adjust that up and down to sort of adjust the overall transmissibility. And then the other aspects of transmissibility are quantified as a relative ratio between A and B. So we have a relative susceptibility per contact, which is QB over QA. The relative overall contact rate, I think this is also should also be AB over AA. That's a typo there. It's generally a B to A ratio. Then we also have these within group preferential mixing levels, which can be different for the two populations, epsilon or A and B, which are those epsilon parameters. The recovery or end of infectiousness rate gamma, which is basically just how long do people, the inverse of how long people stay infectious on average. And then for the vaccination portion, we have the time at which all susceptibles are immunized after time 0, which is when the organism is introduced to a naive population. And then the portion of each group that gets immunized, which is sort of acts as our kind of decision variable for vaccination outreach. So we have this packaged up into an R package, and we have this function that is used by the app, which is kind of the main engine of the calculation, which is called the get final size. So it calculates the final size of the outbreak in both groups after running the SIR model. So basically what it does is it takes those inputs I showed on the last slide, it computes the beta IJ transmission rate values. It simulates the differential equations up to the vaccination time if that time is greater than 0. So it'll simulate the sort of unvaccinated outbreak up until the time where you say vaccinations are distributed, and they're distributed all at once. Then it calculates using some fancy math equation simulation free the final size of the outbreak for each group. And so if you're familiar with R code, this is how you would use it. We've got this vaccine.equity R package on the GitHub that you can import into your library and then just call the function like this. It takes all those inputs I showed on the previous slide. So in this version, the vaccination time is at time 0, so everyone gets vaccinated sort of in anticipation of the outbreak. This version, 10% of each population, A and B, is vaccinated. We have got a 1 million size population with 80% in the majority group A, 20% in group B, an R naught of 1.5. Recovery rate is 1 over 7 days, which means this average 7-day infection. Contact ratio B to A is 1.7, so the minority group has more contact. They both have a 40% preferential contact within their own group and no difference in susceptibility. And then it spits out the final outbreak size. So these are the number of people that got infected over the whole outbreak. You can see more than half of group B got infected, 100,000 out of 200, and much less than that in group A. So we had a disparate infection outcome, which was entirely because of this contact ratio being 70% higher in group B. And so basically the app that Willy will show will let you change all these numbers. And the output of this function gives you the final size in terms of infections. We also can put in other outcomes aside from infections, which basically just multiply these infection numbers in this version of the model. So some portion of people who get infected could be hospitalized, which could also be disparate between A and B, and then can also calculate deaths as a rate of death per people who are hospitalized or not hospitalized, which could also be different between A and B. So you can include different aspects of disparities in those numbers as well. And then we also have sort of placeholders. We don't have it in our version of the app yet. That's something to be done for putting in economic costs for these outcomes as well. Costs of doing the vaccination, which could be different for the different groups if it takes sort of more outreach to get vaccines to one group or the other. And then you could also put in cost numbers for health outcomes like infections, hospitalizations, and deaths. We've got placeholders for those in the code, but not in the app yet, and that's something we can discuss about what you think would be useful to show. I think that's all I have. Maybe Willie, do you want to share the app? Talk about that. Any questions before we get to that?
No, this is really cool, Damon. This is awesome. And okay, so the second last bullet point there, and then second last and the last one. So those are obviously keys for economic evaluations. So from the number of infected that is from the get final size, then what are the consequences of those infections and attaching quantifying the hospitalizations, the deaths, which again you said you could the hospitalization rate, the death rate, those can vary by group A and group B, and then the cost for those. So and so is the idea that those elements will be then built into the app, or are those things that we do on kind of after the fact on the back end? Or I
Uh,
guess at this point, probably the back
yeah,
end, but at some point those get kind of built into the app.
yeah, we're hoping so. I mean, generally, we've kind of had this when we've done these kind of collaborations, we've had it as kind of a handoff. Like we
Yeah,
say,
right,
here's the epi numbers,
right,
health economists, people, take those and run with it.
right.
It's kind of what we did with this model with Nui's team and Danielle Nguyen, who's been writing a paper on this.
Hmm.
She took the model and then she added in some of these outcomes like hospitalizations and deaths
Hmm.
based on racial ethnic numbers
Hmm.
from the literature for COVID,
Hmm.
um, and then did some cost stuff.
Hmm.
But I think it would be worth a conversation today to figure out how to streamline that and have that sort of directly built in
Yeah.
to the model and generate, various outputs around that idea,
Hmm.
including, cost benefit style figures that you guys like to make and stuff like that. We can talk about that as we go forward.
Can I chime in a little bit here? I think this is the presentation is excellent. It comes at the right time because actually Khan has just finished her research work on mobile vaccine clinic and the outcomes of that. And we found significant findings on potential differences in terms of reducing disparity. And also at this moment, she is moving toward doing the economic evaluation modeling. And this model that you have shown us will be potentially a good one that can be collaborated with Khan as well as part of trying to utilize it and incorporate it economic information as part of that. But most importantly, she wants to present the result in terms of distribution, not only the average result, and potentially maybe doing a full-blown distribution and cost effectiveness analysis. But anyway, Kani is here with us, and I'm glad to have a chance to listen to this. And by the way, Daniel would love to come, but she's sick. And of course, we can listen to this later. Yep, thank you.
Right, stop sharing. So
Great. And Damon, I have just another question. So the the input parameters are kind of point estimates, right? Um, uh, and I know like in the past we've kind of run, different scenarios where, we have a high value and a low value and a medium value like for the transmission parameter, for example. Um, which, I'm sure we could use the Shiny app to do the same thing, right? Where run one version with just run sensitivity analyses kind of manually is one thing that we like to do on the econ world is do uh, like probabilistic sensitivity analyses where we're kind of Monte Carlo simulations where you're drawing values for the inputs from a distribution. Um, like would that be possible with this, do you think?
Yeah, I think so. I guess that's worth a discussion about who the target audience for
Uh-huh.
an app would be.
Mm-hmm.
Um, if someone wants to use the R code directly,
Mm-hmm.
then we like I showed on the last slide there, we provide the function.
Mm-hmm.
And so a modeler could, take that function and put it in whatever kind of loop you wanted to just rerun it.
Mm-hmm.
And
Mm-hmm.
the Shiny app could probably be designed to do something like that as well. I
Mm-hmm.
guess we're thinking of the Shiny app as being more of a sort of like a conceptual tool for someone to play with and get a feel
Right.
for the interactions. But I guess, yeah, I guess it depends who the target audience for the app is, right? Oh,
Right.
Yeah, I guess I think if you had a real experiment in mind, you would use this app to sort of get your head around what the model was and what the model did,
Mm-hmm.
and then you would install that. You would install our package,
Mm-hmm.
and then write a loop around that
Mm-hmm.
package to vary the inputs in the ways that you wanted. I think yeah, I could imagine it being done the other way, but
Mm-hmm.
yeah, I don't
yeah,
know.
you could have like max min of different parameter fields and then have like a run
Have it run 1,000 times.
run run Monte Carlo button or something like that.
Yeah,
But
Or like, yeah,
yeah,
so
for
like
sure.
like the population setup, if you had, hospitalization probability for population A is 0.017, but there's a standard deviation of 0.005 or something, and then use those as parameters for like a beta distribution or something, and then run 100 or 1,000 Monte Carlo simulations, each one with a draw from that for that input from that distribution.
But I feel like it comes back to what is the purpose of the
Yeah, who's the user
yeah,
of the app, right?
Right.
exactly.
Yeah,
And whether I'm sure that uncertainty is very important, but I'm sure that they want to see the point estimate first, how it changed. And
right.
we might need to add some anyway, I need to listen to this, but I'm thinking of visual presentation and
Hmm.
eventually have that uncertainty part to be shown at the end because it might confuse the audience if they don't know exactly the purpose of considering uncertainty as part of the model.
Hmm. Yeah, for sure. For sure. Bottom line,
Okay.
this is awesome, you guys. Fantastic,
Well,
Damon and Willie. We're excited to see what the app does.
well, um, these are all the parameters that Damon was talking about. And you see, we set up the two populations the way they are. And out here, we get a table that gives us the results of the calculation. And I think that you were asking, Rich, about the number of infections, the number of hospitalizations. I
Uh-huh.
know that you guys take these kinds of things as inputs to your calculations a lot of times.
Uh-huh. Yep.
And I think these are the ones that kind of occurred to Damon and occurred to us on our end. I think that this death percentage value is an interesting one. As we change the number of vaccinations um, in the smaller population, you see not only that it's changing the death rate in Group B, but it's also having a considerable effect on the death rate in
Right.
Group A.
Right.
So that's interesting. All of these values are editable. And the other thing that's neat about this is that it's on shinyapps.io.
Hmm.
So we went ahead and deployed it because we figured we might as well. Damon, I'm not sure what you want me to say about the math of this. I don't know what particular features you want me to show. I've got a
Yeah,
sales
you
I've got a
can,
sales pitch for the CFAR programming group. But if you want to, what do you think I should show here, Damon?
yeah, I mean, you can, I think, it's also possible to display functional outputs here. So that's another way you can sort of depict a range um, to to get a visual um, curve for, say, how increasing vaccination in one population improves outcomes in that population or in both populations.
Hmm.
One thing you can do with this is, the sort of percentage rows of the output when you compare A to B give you an idea of different measures of the disparity. Um, so you can see here, yeah, yeah, you can sort of play with, how since population B has the higher contact ratio and susceptibility ratio, then they're disparately affected. And so you can sort of try to figure out how much more vaccination does group B need in order to achieve equity in the different outcomes, right? Comparing the percentages. So in this version, there you can sort of, maybe Willy play with that, decreasing that population B number until, say, infection disparity or infection percentage comes out about equal. You can sort of get a feel for how
I see.
much.
Okay, so I'll start at equal, both
Yeah. So they're
30%
both
vaccinated.
30% vaccinated here, so they're equal on vaccination, but
This
they're
is
43% of the population got infected versus only 34% of group A.
Hmm.
And so you can kind of increment up that to see how much more heavily vaccinated would they have to be in order to achieve equity in the different outcomes. And so there you can see at a 42%-ish vaccination, there's an equity in the infection outcome, but there's still pretty substantial inequity in the hospitalization outcome because of this hospitalization probability input
Yeah.
over here being higher. So you can see that, equity at infection has been achieved, but equity in hospitalization has not yet been achieved at that level of vaccination. And you just sort of get that's one way to play with the app, at least in this version. Well,
yeah, I don't know.
Yeah,
As we
super
step
cool.
this, things change considerably. Um,
Yeah, and so are you, so that, I mean, to our earlier question that we had, so are we envisioning this as the end user being like folks in a public health office in a at the state or in a local jurisdiction, kind of
um,
looking to see like what if we deployed our vaccine program a little bit differently, or if we knew these input parameters for a couple different groups in our community, is that kind of the idea?
that would be amazing.
yeah.
I mean,
Um,
I think it's pretty specific.
Yeah,
You'd have to know these parameters for,
right. That's what I was gonna say is would these parameters be ones that like the folks that we've been talking with at DHHS, but are these input parameters that they would know? Like Jessica, I'm trying to remember her last name. Like, would she know these?
yeah, the input parameters are one um, thing that is worth discussing
Hmm.
because yeah, it's a whole separate project to figure out what these parameters are based on
Right,
an outbreak that you're
right.
seeing.
right.
It's easy to make them up and explore
Hmm.
what's happening. I guess that's one thing worthy of discussion. The paper that was sort of inspired this was based on COVID in New York City in the early, sort of pre-vaccine stage, where they looked at different outcomes in different racial and ethnic groups. And they were able to sort of fit different versions of this kind of model to that data to figure out what the mechanism might have been. And then looking at some like demographic data in terms of where people in different racial and ethnic groups live in different neighborhoods of the city to get at this contact within group parameter. Um, but it's not trivial to figure that out for a particular population. Um,
Hmm.
and in terms of being used by public health, aside from that issue, it definitely sounds like a lot of the feedback we're getting from them is that the economic style arguments are pretty impactful for them.
Right.
So it's another thing that's worth
Right.
discussing, like what
Right.
how does their decision making or sort of resource allocation type decisions translate into a model like this,
Mhm.
and what would actually be useful as like a decision making tool.
Right.
Um,
Yeah, because if you had input parameters that were like, direct cost per vaccine, and then, cost of a, what if it's an education program, or what, like a program to increase, fixed cost of a program to increase vaccination uptake, but then, direct costs of the hospitalizations, uh, uh, if you want to get really wonky in econ, you could attach, utility values to the hospitalizations and the infections themselves, to generate quality adjusted life years. But if those were all kind of parameters, and those you could very conceivably think that a public health person might have some of those input parameters, and could play around with those, and then have those also spit out on the output panel, would be super cool.
Probably the hardest one to put real data behind might be the contact ratio. If it's
Hmm.
not something like your school where you did the actual time
Right.
and motion studies.
Yeah. Yeah, I agree. That one seems like it might be a little bit hard to pin down.
yeah, one of the interesting things that they concluded out of the New York study of early COVID was that they compared a model that put the sort of disparity mechanism in the contact ratio versus the susceptibility ratio, which produces somewhat different dynamics. And they concluded that it probably was mostly contact difference as opposed to the susceptibility difference for the racial disparities in New York in early COVID that they found, which was interesting. Um, but yeah, to get direct numbers on those is another thing that's difficult. So you'd probably want to explore sort of sensitivity to those assumptions and how the vaccination results come out. Well,
Hmm. Well, bottom line is, this is really super cool, and there's a lot of neat stuff that we could do here, from the econ side of things.
Let me
And
let me give
yeah,
you my collaboration pitch, Rich.
yeah, 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 yeah. We'd love to hear it.
Um,
We're skeptical. I don't know. Like,
so
sell us, Willy.
at the beginning of this project, at the beginning of the work on this project, what I was handed from Damon was basically an R script that had these functions in it that could calculate on the console the values, and a
Hmm.
little bit of sort of starter Shiny app
Hmm.
stuff.
Hmm.
And what I want to show, what I want to make clear is that at the end, Damon's original file that started at the beginning is basically untouched.
Hmm.
I've not had to copy and paste it into a bunch of Shiny stuff. It lives still on its own file that Damon could edit if there were changes that needed to happen to the math.
Hmm.
This is a capability that the R programming group has been very deliberate about trying to develop, because it's our assumption that out in our enterprise are a bunch of very useful R scripts
Hmm.
that are in lousy states of code or unshareable states of code. So the idea here that I'm suggesting, that I hope that you guys can take away and think about, is that there exists this R programmers group that's funded by the CFA that has the capability to take an R script like this, turn it into a package that can be installed directly from GitHub into your R environment, and also turn it into a Shiny application that looks like it was made by someone who makes software, a programmer. It looks like a professional piece of software. And what I'll just demonstrate real quick, things like the tooltips,
Mm-hmm.
right?
Yep. Yep.
Are my way of saying this is real,
Right.
right? This isn't thrown together.
Mm-hmm.
Or if I were to take this and put it at the wrong,
If you were to kind of break the model. Yeah.
I get validation of the user inputs.
Mm-hmm.
I can have a multi-page display that lets me put whatever the heck I want to, whatever needs to be put on here, to square it with the CDC, right? When we do stuff, we have to put their language on there, stuff like that. So yeah, that's my message from this thing is, yes, this is a pretty cool little app that we built. And I know you guys have got a lot of ideas about how it could be useful or different or other things, but I also hope that you can go away thinking about whether or not there are scripts in your folder somewhere that could be valuable if given the same treatment. And if so, you can get in touch with me, or you can get in touch with George, or you can get in touch with Damon.
Yeah, I love it. That's awesome. That's fantastic.
Yeah, that's all I have, unless there are questions about the software side. I'm not a scientist. I'm a science adjacent programmer.
No, we learned a lot and really enjoy this stuff. And I feel like this is exciting work, and I can see a lot of applications in various ways. I know I posed several questions before, and we can talk later. But I think, as Rich mentioned as well, that in order for us to use from economic standpoint, we want to look at from the output that has spit out over time, and also the input that I hope that it can be changed over time, because that probably the real world situation that the
Yeah,
input can
a
be changed
parameter
as well.
sweep, a sensitivity analysis, and also some sort of input that models uncertainty in those values.
Yeah. And
As it
then
is, I mean, if you were in an argument with somebody and you said, if we've got these two populations and they're different in some way, there exists a circumstance where if we put more energy into the smaller group, we'll get a bigger yield. We'll get a better outcome in the end.
Right.
If someone doesn't believe that, right now, this is a tool that
you could show them that.
can make that argument,
Mm-hmm.
right? But definitely, the sky's the limit with what could be added or changed.
Yeah. And so to Newey's point, so Damon, as far as the model itself, the time horizon of the model itself, like, is it possible to, like, is this like over a 1 year period, or like what is kind of the time horizon on the current model? And is it possible to either change that time horizon or make that time horizon explicit in kind of the outcomes, like to say, kind of, I guess maybe it's epicurve wise, like to say here's when the infections occurred in group A, here's when they occurred in group B. So on the econ side of things, we can attach discount rates to outcomes that happen way out in the future to be able to compare those future outcomes with current costs in the present, and have more of an apples to apples comparison there. But so something like that would be really neat to be able to do, to compare that, because that's a big question a lot of decision makers have, which is, I'm investing money now, but the benefits may not like come to fruition for several years in the future, and I want to be able to compare the cost down the road and the cost now with each other today.
Because they're standing in the shower and they turned the cold knob a little bit, and now they're waiting for the temperature to change.
Exactly. Yeah.
Yeah, that time feature would not be hard to add. The components are all there already. There's the outcomes that we showed are mostly the final size. outcomes, which is basically letting the whole outbreak play out. Which you can do in an SIR model if immunity is permanent. Um, but I guess as that's not always true, so it might be more safe to say that it would represent like one whole flu season or something like that.
Right.
Um,
Right.
but the time component is already built in there to if you change that vaccination time component, it will simulate the unvaccinated outbreak up until the vaccines are administered and then calculate from there. So that component is already in there to have to simulate out to whatever time you want. So if we think that's a important feature, we could
It's a run up to
add
the
as well.
intervention, right? An outbreak with a run up to
Yeah,
the intervention, kind of an
you
idea.
could also stop the post deployment model at whatever time you want to show number of infections in the first and after certain number of months or whatever you wanted to.
Hmm. Oh, see, Andy, I see your mouth moving, but I see you're muted.
Sorry, I just had somebody come into the office. You had, I think when time of vaccination happens, it's everyone is vaccinated in the way the model's set up.
Yep.
Yeah. Which isn't, usually what happens. I wonder if it's possible to do fractional vaccination over X period of time. Certainly fits better with Khan's approach to, think about vaccination as being something that occurs over time.
Hmm.
Yep. Yeah, wouldn't it um yeah, if the vaccination was applied like as a rate, then it would change the differential equation, but that wouldn't be hard to put in.
Yeah. And I guess you could have differential vaccination rates between the groups, right?
Yeah.
So, uh,
Yeah, or you could have a state, you can model it as sort of a staged,
Yeah.
That's what I was going to suggest. That's probably a simpler intermediate implementation would be to stage it.
Yeah. And
mhm,
that way you could, I was thinking about Khan's question about interventions. One group could have more rapid implementation than the other, or you could see the
right,
impact of more rapid implementation.
right, right. Yeah, that would be really useful. I could see that being super helpful. Okay, so bottom line is I think this is like really awesome, super exciting, and I think we would be happy to help make this tool even more useful.
Yeah, so I think in the next step we already have some example estimates of cost values that are from Danielle's
Hmm.
work on and she presented on this in the abstract that we cited that Willy showed for second there
Hmm.
and is working on a paper. So I think probably next on our list is to add in some of those cost components just to be able to show what those kind of outputs look like.
Hmm.
And then I don't know, what do you think is the next step after we sort of knock off our short-term to-do list here?
Yeah, I think taking Danielle's inputs, that would be low-hanging fruit for incorporating the econ side of things into it. And I forget if yeah, whether qualities is that important enough to be in phase one, or do those need to be, are those less important and could be phase three or four or something? Um, so I would say like the parameter uncertainty would that would be really neat and cool. Um, uh, let's see the timing. I think the like vaccination uptake would be I think that would be a neat thing to include and probably
So you think at this point, just continuing to add some more features?
layers and features to make it, yeah, to make it
Yeah.
more useful for a number of different applications. Yeah, I think so. Does anyone else have any other stronger opinions on? I guess one question would be what is the short-term goal for this? Is it Is it to answer a certain question, or is it to make a cool app that we could maybe show someone at some point? Or is there an intended audience here soon that we might want to show this to?
I proposed just more like a mixing everything together. I think the audience should be the public health officers.
Mhm.
And the good thing, sorry, going back to Khan work that she's trying to do the effect of mobile vaccine clinic, which I'm sure the public health officer would be eager to see that.
Yeah.
Somehow using that kind of examples and put a little bit more information, both visual presentation and numerical number to be showing to them and try to assess how public health officers perceive and use it, whether this is information would help them make a decision in the timely fashion when they need to handle things, pandemic or something. I'm just proposing, just a thought.
Yes, I'm also thinking maybe regarding the output, we can classify the health outcome, the non-health outcome, the economic outcome. In economic outcome, we can have the, like I said, the microeconomics, for example, the hospital cost, the infection cost, the death cost, and also the macroeconomic or also the health effect, so that we can capture the public value of the vaccines. Yeah. And I also think that for this model, we can estimate the cost effectiveness of vaccine. And beyond that, we can estimate the cost effectiveness of vaccine program because it's different from vaccine. For example, in mobile vaccine clinic, if we apply it in when the baseline vaccination rate is low, it has higher effect than we apply when the baseline vaccination rate is lower. So that maybe, and also we can estimate the return on investment for the vaccination program. Some thought like that, yeah.